It's nice to be asked to speak with you folks. This is an area that I think is incredibly important to people, and kind of in the middle of it and down the road, I'll be talking about the difference between doctors talk about complaints. Complaints are simply symptoms that we talk about. It's not complaining. But the literature on the difference between memory complaints and actual memory disturbances that are objectively found is a pretty interesting one. So I'm going to be focusing on both what people experience and what we know about the brain. I'm going to start off by talking about what memory is and what it isn't. And then next talk about how epilepsy and seizures can specifically affect memory differently from other conditions. And finally, how to optimize brain health and memory functioning. And there are a number of things that we can do. So let's hope this all works here. Whoops. Now, why is that? Okay, good. Before I got trained, I kind of thought memory was a little bit like you hit the rewind switch on the in those days, VCR, and you'd get your memory, but it really isn't. It's not that kind of a process. It's an active or dynamic process which constructs memories that we want to have. So if I have a thought that I want to remember what I had for breakfast yesterday, I have to go through a whole bunch of associations: food, not dogs, not presidential candidates, not today, not, and it immediately, very quickly goes to maybe breakfast yesterday or whatever my memory is that I want. And different aspects of memory are stored in different parts of the brain, and that's part of why this construction has to kind of run around and hit different areas in order to retrieve and create a memory. Memory is a process, as I say. It's there are a number of steps. First of all, we have to register something. We have to perceive it, hear something, see something. And our attention has to be able to be focused well enough to be able to encode it. So a little bit like Tom Cruise in the Missiles Without Hurting Anybody, where that locks on the radar. Our brain automatically does that. It focuses our attention, then it encodes whatever it is. It goes, okay, this is something visual, or all these different sensory aspects to it. And then there's an automatic process called consolidation, where it's kind of guided by unconscious processes. So if something's not important and you're walking down the street, your brain isn't going to consolidate everything it sees or you hear. But in general, in our lives, if things seem important to our brains, they'll consolidate, put it into short-term storage, and then it goes into long-term storage, which is around the brain in different areas. And then we have retrieval, and we want to get it back. And sometimes we can't get a memory back. Someone will say, I'll say, well, I don't really remember that. And someone will go, oh, don't you remember blah, blah, blah. The person was wearing an orange clown suit who came over and dumped paint on you. Oh yeah, all right, that jogs my memory, and that's recognition memory. Memory is also divided into different categories. And if you ever saw a neuropsychologist, we would be looking at all these things a little bit differently. Declarative memory is what most of us think about as memory per se. And it's divided into episodic and semantic categories. And episodic memory is simply remembering events that have occurred. It's our autobiographical memory. It's remembering, oh yeah, that party last week. I can remember the people there. I can remember going outside earlier today and seeing the car windshield needed to be cleaned off and I forgot to do it. That's episodic memory. Semantic memory is fact memory. That's remembering that we have a new president, for example, thank heaven. It's remembering my address. It's remembering information rather than episodes of experience. Now, there's also non-declarative memory, and this is unconscious. When we learn to hit a tennis ball, for example, our motor skills, every time that we practice, hopefully, we get a little better. And that's our memory learning steps to the process without our actually having to think about it or declare it. Other aspects of it are classical conditioning. If you've ever had a food that really tasted awful, made you sick, food poisoning, and the next time you see that, you may, without being conscious of it, feel that I don't, just a terrible sense about that. And that's an unconscious memory, but a condition, classical condition. When we learn, when we have habits that we do over and over again, we get better at them. Those are unconsciously learned. And then there's also facial recognition memory. And that's in a special place of the brain. The brain sits on this plate and it's in the bottom part of the brain. And when that gets hinky, we have a condition called prosopagnosia, where people don't remember and can't tell faces and don't know who it is. In the most severe form of that, people can't recognize themselves in the mirror. And all other aspects of thinking and cognition and even memory can be just fine, but they cannot remember faces. Now, this is an important part of any epilepsy surgical workup, any of you who may have had an experience with this. But we've been taught to think about right brain and left brain, and that's kind of a flaky thing because the brain always works. All of it is always working. There's no part that's absolutely shut off. But in general, with virtually all right-handed people and almost all left-handed people, auditory and verbal memory, remembering, facts and remembering names of people and things like that, even remembering a lot of episodic events, are lateralized. That means they're stored in the left memory area of the brain for right-handers and most left-handers. Interestingly, although verbal memory is over here on the left very strongly, visual and figural memory is not as strongly lateralized on the right. And this is why we neuropsychologists, when we're working people up for epilepsy surgery, we need to know where the different functions are. So when the operation takes place, we know what's going to be left and how to protect the brain of the person being operated on. It takes quite a bit of time because we're making a lot of inferences. Verbal memory very clearly on the left for almost everybody, but visual memory, to try to protect that, is a little trickier because it's kind of distributed around the brain. Now, we can also think about time and memory. So obviously, a lot of these seem obvious: short-term and long-term memory. And there's prospective memory. That's remembering something that we want to do or that's going to happen. So we can divide memory into those time periods. To jump down at the bottom, recent and remote memory you'll hear talked about, or immediate and delayed. They're really kind of the same thing. They involve slightly different time periods depending on what's going on. So for example, in the normal life, we think about short-term and long-term recall. But if you're doing testing with a doctor like me, we talk about immediate memory, which is right at the desk, and then delayed, which might be a half an hour later. Anterograde memory and retrograde memory are just, again, terms you may run into or hear. Anterograde is the ability to learn new information and remember new things. And retrograde memory is, again, backwards. It's the ability to remember things that have already happened in time. Now, memory function is very commonly disrupted in epilepsy and seizure disorders. And the reason for that is just an anatomical one for the most part. Largely, memory is, again, the learning and the new memory is stored in the medial temporal lobe. Medial means in the middle of the brain. The temporal lobe is the lobe on this side of the brain. And that's the most epileptogenic area of the brain. And that's why when we have complex partial seizures or temporal lobe seizures, focal partial seizures, they're occurring in that area of the brain most usually, and that's right where memory is stored. So epilepsy just has a predilection for messing with our memories. Now, the frontal lobes of the brain also, they do something a little different. They are the planning, organizing, executive part of the brain. And so in a moment, I'll talk about how frontal lobe seizures also disturb memory in a particular way. But then again, there's all sorts of things that go along. We call them comorbid. They go along with seizure disorders. Look, people get older and memory gets a little less good. I can tell you, having turned 68, that is true. sleep problems, substance use, stress, depression, anxiety, all these things on top of seizure disorders, and they're common with everybody, also affect memory in particular ways. Now, people often ask, will my memory get worse over time if I have seizures? And there's back when I started doing epilepsy, in Epilepsia, which was it still is the big international journal of seizure disorders, January 1st every year, they would have two doctors arguing. One would say seizures create permanent problems, and the other one would say seizures don't create permanent problems. And I think you can take both sides of it in some ways. But a lot of people want to know will memory get markedly worse over time? And there is a proportion of people in whom we do see progressive decline in memory with seizures. Not everybody, and not everybody with these characteristics I'll mention has progressive decline, but it's most common with these factors. If people have had epilepsy for more than 30 years, if the age that their seizures emerged was before the age of 5, people who've had more seizures in their life, more than 50 or 100 seizures, are more likely to fit this category. And then people who have to be managed on more than one anti-epileptic drug. You put all those things together, and if someone fits all of those categories, it's not uncommon for them to complain over time that their memory is gradually getting worse and is changing. Now, this is just some figures that show how often memory and cognition is affected in seizure disorders and epilepsy. And it's just a common factor. Not everybody has it. I'm not going to go into detail and take a lot of time. You can see it yourself. But what we know is that it is a more common phenomenon than it is in the general public. Now, where the seizures originate, the seizure locus, we call it, like location, also affects memory in different ways because, again, long-term memories are stored in different places, and we have more visual and spatial processing toward the back of the brain. We have on the side and lower down, we have more speech and language areas. So different aspects of memory can be affected depending on where the seizures come from in any given person. But typically in temporal lobe epilepsy, mesial temporal lobe epilepsy, we see what we would normally think of as memory problems occurring. That's that ability to consolidate information, to retain it, to recall it later on. The ordinary kinds of memory we think about is stored in that area and organized in that area. And so with temporal lobe epilepsy and complex partial seizures, we're likely to see retaining and retrieving information. It doesn't feel like it's in there. We don't retain it quite as much. And that's because that, again, the hippocampus in that middle area of the brain, there's one on each side. Those are the two little organs in the brain that are just essential for retaining information and for recalling it. But patients who have frontal lobe seizures also have memory dysfunction very commonly. It's a different kind though. First of all, it tends to be less severe than the temporal lobe patient. But what it results from is the organization and processing of remembering rather than retaining it and holding it so much. So the frontal lobes, again, they strategize. And if we have to remember something, the frontal lobes have to go, okay, I want to remember, as I said before, food or breakfast, and have to go for that specific thing and have to say, well, I'm not going to go through this, and this is the most efficient strategy to come up with that recall. If the frontal lobe, which is doing that kind of processing, that organizing, that it's doing the efficient search, has seizures coming from there, people can have trouble remembering, not because they haven't retained it, not because in a sense it isn't in there, but because they can't find it very easily. And so that memories can become disorganized, and people remember things out of order more, but it's not so much people don't remember things per se. I talked about memory complaints and memory impairment, and it's interesting. This is true for virtually every neurological condition, but it's clearly true for seizure disorder folks as well. The degree to which people experience memory problems, and we talk about complain about them, and it's proper to do that with our doctors, is very poorly correlated and associated with actual objective memory impairment. And in epilepsy, that's probably because depression in the brain, anxiety as well, and stress, which are if people are depressed and they're feeling distressed, they're more likely to report memory problems than if they're not. And so we're getting a kind of a confound, we call it. These things sort of overlap, and sorting out how much is caused by the seizures, how much is caused by depression gets tricky. And that's, again, part of the job that I do, is try to sort those things out. More memory complaints occur in people who are on more anti-epileptic drugs, and people who have more seizures, obviously, will say their memory is worse. And then, interestingly, maybe a little less commonsensical, is the idea that people who experience their epilepsy or their illness as being more severe and more problematic will typically have more memory problems. And that may, again, just sort of seem obvious, but it's interesting. It doesn't always hold for every condition. And there are conditions in which people will have extremely severe memory problems and not perceive their illness as being a problem at all. So there's a strong correlation in seizure disorders. Now, in seizure disorders and epilepsy, there are some very specific memory disorders that occur in memory problems that don't occur in other conditions. Excuse me. I'm sure you all know about status epilepticus. Status epilepticus is basically defined as having more than one seizure in a 5-minute period, continuing to have seizures without their stopping, or a seizure that lasts a long time. This is a medical emergency. Patients sees in my office all the time. Don't call the ambulance and don't send people to the hospital. One seizure, as virtually every one of you, I'm sure, knows better than I, when it's over, it's over. And people need to rest or relax. They need to sometimes take an extra dose of medication, but don't need to be in the hospital. With status epilepticus, people do need to have medical attention to make sure that process of seizures stops. And status epilepticus can cause permanent and persistent memory problems if it's severe and it isn't stopped and taken care of in some people. And the first thing that usually occurs is people will have trouble with problem solving more than anything else, figuring out how to do things and what to do. And that'll take a memory kind of form at first, and later on it's more of a strategizing and organizing problem. But memory does get affected after episodes of status. Happily, for many people, they can have an episode, of status, or a number of them in their lives, and they don't have permanent damage. But it is not uncommon to see that. There's a very interesting set of problems. I'm going to talk about it in terms of 3 different things: autobiographical amnesia, what's called transient epileptic amnesia, and accelerated long-term forgetting. Those are all of a piece, and we're going to go through those now. A lot of folks with seizures complain about autobiographical memory impairment, and that's remembering experiential things people have seen or experienced in a context of a time limit, what happened when, the details of that. It's not the kind of thing that's common in a lot of other memory problems, but in epilepsy it is. It's associated with more chronic seizure disorders. Again, seizure disorders that are intractable or hard to treat. Depression, if people have had a younger age of onset. And again, it's a very common part of this TEA, which is transient epileptic amnesia syndrome. Now, frontal lobe epilepsy patients, seizure patients, can also have autobiographical memory impairment. But it, again, typically isn't that they don't store the memory and don't have it in there to have trouble recalling it. It's more that it's out of order. It's not organized the way that one would expect. I have patients who come in and when they're giving a history, they forget that they had this operation last year and their car accident was 2 years before, and they get those things confused. They remember those things. So it's not a retention problem, but getting them organized and calling them up in order is difficult. Now, transient epileptic amnesia is a really important syndrome. It's extremely under-recognized and underdiagnosed. I've seen a handful of people I've diagnosed with this through the years. And it's an interesting thing. People come in and they complain that they can't remember episodes from their life, significant things, really important things. And they're often quite distant things, but they can be continuing throughout their life. And everything else seems normal. All of their cognitive functioning is good. They're doing well in their jobs or at school, in their lives, but this weird inability to remember things that happened to them and they participated in, sometimes very important and very striking. The most recent one that I remember was somebody did not remember he had been on a cruise 6 months before. That was a year or so ago, obviously. Couldn't remember it. And when people showed him pictures, couldn't remember it. It was gone. And these transient epileptic amnesia can take a couple of forms. It's not always the same, but it's most commonly thought to be recurring episodes of amnesia. They're very common to be experienced when people wake up. Not always. People can have them at any time during the day. And during this episode of this transient amnesia, people have trouble even remembering. They can't form new memories about things. So things that are going on during it don't get remembered later. They also have difficulty remembering sometimes very significant things that occurred just a few hours before or the night before, the day before. An interesting problem with this very commonly is people lose the ability to remember themselves in space. So I had a patient who experienced this and came out of the bedroom and could not remember how to get to the kitchen in his own house. He just couldn't remember it. The topography, the mapping in the brain got glitchy during that time. These episodes commonly last about an hour. Everything else is normal. Speech and language function, motor function, people's behavior, except for the distress about this, completely unaffected. Now, it's more common in middle-aged adults, and I guess I'm thinking about the last couple of people I saw were probably in their 50s. But again, it's experienced by patients as being very weird. And sometimes doctors will misunderstand this as being psychological, that, people just don't want to remember these things. And it's not that at all. It's a very specific syndrome, and it only occurs with epilepsy. Now, part of what happens in this is ALF, which is accelerated long-term forgetting. People with this kind of syndrome in epilepsy will normally learn things while they're happening. So they'll recall things for a short period of time. So a person goes on a cruise for the next day, sometimes weeks, sometimes even a month or two, will remember that fine. But then their long-term forgetting over time, long-term, they forget in an accelerated fashion. So they begin to forget things much faster than people would otherwise do who don't have this syndrome. And so it can be immediate, it can be just a few hours earlier, it can be quite distant events, remote personal events. And if anyone experiences this, it's important to make sure that your doctor considers this as a condition. It's usually very treatable because it's usually a matter of breakthrough, we call them breakthrough seizures, occurring in certain people's brains. And if you get those seizures under control, you can stop this process from occurring. You can't regain the old memories, but you can stop the new ones from being lost. Now, everybody knows about when you get an EEG, you either have a seizure on it or it shows nothing, or very commonly with people who have seizure disorders, you'll get these spikes that don't turn into seizures, but they occur interictally. Ictus means event or the seizure. Interictally is between seizures. So in between seizures, you can do an EEG on someone wide awake, having the EEG done. But if you have a seizure disorder, you can get these isolated spikes. Now the spikes, even though they don't turn into seizures, have been shown in a couple of important studies to cause momentary memory impairment. Depending on where the spikes occur in the brain, it could be about verbal information, it could be about visual information. And it's just a brief moment of a disruption. I think about an Etch-a-Sketch. If you remember those red plastic things with the gray screens and you could draw something, but if you shook it, it disappeared. And the idea is that these interictal spikes can affect memory that way. And they often occur during sleep. And if they do, they interfere with what our brains are normally doing about the day, where we consolidate our memories during sleep. That's one of the important things that sleep does. I'll talk a little more about that in a minute. But even though you may not have a seizure, the spikes themselves may be disrupting your memory and your learning and your holding on to things. I'm not going to talk much about anti-epileptic drugs and memory. Every patient who's had an experience on the medications knows better than I how these drugs can hit you. My experience as a doctor is a little bit different from some people. I believe everybody. I have had patients come in, very commonly with cardiologists, interestingly, who are horribly depressed on heart medicine. And the cardiologist says, nope, can't happen. Isn't what's causing it. And we talk them into changing the medication. They change to something else and the depression lifts. So it's possible to have side effects on things that most people don't, and it's possible not to have side effects on things a lot of people do. So looking at all of us individually, I like to think that's what neuropsychologists do, and not just sort of saying, well, if this, then that, but rather who's this person, what are they experiencing is necessary even with the drugs. But there's some basic things we can say. Topamax, Zonegran, and Tegretol, it's more common for people to experience memory problems on those medications, although more common at higher doses and for longer periods of time. A lot of people tell me they call Topamax Dopamax. And these are pretty significant problems that people will have, and it's just a proportion of the patients. For many people, Topamax, Zonegran, and Tegretol are great drugs. They don't cause major side effects or memory problems, and they're well tolerated. But these are the medications that we tend more often to see memory problems occur with. The other medications I list below, you can see them in some cases. As I say, everybody's different, but it's pretty rare. And in fact, in some cases, Lamictal tends to, I think people tend to actually feel better and do better on Lamictal cognitively at times. Okay, other things go on and make memory bad, and epileptic patients have these things too. And depression and anxiety is just an obvious one. I'll return to that a little bit later. I do want to talk about non-epileptic, psychogenic non-epileptic seizures. They used to be called, and some places still call them pseudo seizures. I don't like that because it sounds like they're made up, or they're pretend, or they're fake, or people are faking it and they're not. They affect people exactly the same way that epileptic seizures do, and they're very hard to tell the difference between. Sleep disorders, and we'll talk about that in a minute, foul up memory constantly. And that's true in the non-epilepsy population too. In my practice, the biggest imitator of Alzheimer's disease is not recognized, not treated sleep apnea. Because as people's sleep apnea gets worse, their memory gets worse, and their doctors think, oh, he or she's got Alzheimer's. It turns out if you do a good sleep history, they have sleep apnea, you treat the apnea, and people bounce back to some extent, sometimes remarkably. And then substance use, marijuana and alcohol affect memory as well. I'm not going to go into a lot of detail about depression, except to say that it's very common in refractory epilepsy, but pretty common even in people with well-controlled seizures. And if you look down at the bottom, over the course of people's lifetime, if you look at all epilepsy patients, about just under 20% will have a significant depressive disorder, while about 10% of people who don't have epilepsy will have a significant depressive disorder. But depression and epilepsy is usually different from what we call MDD, which is major depressive disorder. And that's the general psychiatric term. The symptoms tend to be similar, but they vary a little bit more. And rather than a hopeless, despairing kind of depression, which can occur, of course, in epilepsy, but it's not the common form, people feel off, dysphoric, more irritable. It's harder to tolerate stress. Anhedonia means not enjoying things as much. Anergia means just feeling slow and kind of no energy, and then insomnia. So that typically is the pattern of depression. Now, there are two specific syndromes that can occur in epilepsy, and they're important to sort out and don't always get sorted out. Seizures themselves can involve what we call a preictal depressive episode, and that can be days before, where people start to get depressed before a seizure occurs, and then the seizure occurs and the depression stops. That's not true of a major depressive episode, which can go on for weeks or months. Auras that people have before having seizures, about 15% of them have a real depressed quality to them. On the other end of the spectrum, you can have a post-ictal memory depressive episode. Now that's a little bit more significant. It's more, people experience it as more sad and down than the preictal. And this can occur, so people will have a seizure, and then when they come out of the seizure, they experience a notable depressive episode. And it typically clears up within 24 hours. These are not the depressions that last and last and last. Now, why is sleep so important? Well, it turns out that one of the things sleep does for all of us is it's critical as a part of the process for consolidating and anchoring our memories. And that's why a lot of times it's very helpful. In fact, one of the good strategies for learning things better is to study them, learn, get some information in, and then lie down and just relax and kind of let your mind go as relaxed as it can, sometimes a nap. And during that nap, your brain is going to consolidate that information better than if you just kept trying to learn. So sleeping at night is part of what makes our memories anchor. Now, declarative memory, the autobiographical memory and episodes of life and verbal information and that kind of thing, that occurs during non-REM sleep. So REM sleep is the dream stages of sleep. Procedural memory, our tennis swing, bowling, riding a bicycle, swimming, interesting, that's consolidated during REM sleep or dream sleep. And if you think about it, it makes sense, because REM sleep is the dreams when we're acting things out, and that's what motor learning involves. And so acting those things out in our dreams in that stage of sleep helps that kind of memory function optimize. And epilepsy disrupts in general, the hippocampus, as I said before. That's that little area of the brain that's in that very epileptic area of the brain in the temporal lobe. And it's just more involved in that area. So we'll see just sleep being less efficient even when people aren't seizing. Sleep deprivation, you know, I'm sure it's a well-known factor that increases the likelihood of seizures. So it also increases the likelihood of these interictal spikes. And the more sleep deprived people are, the worse their seizures tend to be, and the worse memory tends to be. You know, guys my age at 68 should not be on call. I was on call for a friend who could not get anybody. She had to go out of town pretty urgently. I used to be in a call group with her, and I said, sure, Carrie, I'll take call for you. I was up all night long with patients. The next morning, I get in the car and I'm on my way to work, and I realize I forgot my briefcase at home. I don't forget my briefcase usually. Go home. Yep, I'm back on my way to work again. I forgot it again. I went into the house, I fed the dogs, which I realized I'd forgotten to do. I got a call from Sandy, my practice manager. I totally spaced out that I needed to get my briefcase again, and I went back in. Now, I don't have Alzheimer's disease, I don't think, and I don't have a specific memory problem, but sleep deprivation can tip you over, and it will tip somebody older over like me, or somebody with a neurological condition much more easily. Sleep apnea, as I mentioned before, is a very, very important factor in memory function in seizure disorders. Sleep apnea is, there's two types, and they can have a mixed type. One type is central, and that's where the brain itself just stops the body from breathing. And the other type is the kind of the heavy snoring, and where the oropharyngeal cavity gets real floppy, especially when people are on their backs, especially if the angle of the oropharynx is compromised at all, and that can be genetic. And what happens is people stop breathing during the night, and you can stop breathing 100, 150 times. For 1 second, for 5 seconds, for 15 seconds, for 20 seconds, for 3 seconds. And most people are unaware that they have apnea. But during the apneic periods, it means that your brain is not getting any oxygen in your neural cells at night. And that obviously, I guess I would just say in a common sense way, disrupts memory and other aspects of cognition. Now, that lack of oxygen going to the brain cells also makes it more likely people will seize. And it's very interesting that in the seizure disorder population where I heard Gaitha was on here, I haven't said hi to her yet, but she knows that one of the things that I always look for in our seizure surgery meetings is, does this person have sleep apnea that hasn't been recognized? Because they can be on a boatload of medications and still have breakthrough seizures, not because the seizure disorder itself wouldn't be controlled by the medication, but because the unrecognized apnea is continually sabotaging the medicine and causing seizures. We take care of the sleep apnea, and some people don't need surgery at that point. Now, it's always an individual decision, and sometimes it doesn't work that way, but it always should be considered. Alcohol use. I'm sure everybody here knows that drinking beverage alcohol lowers the seizure threshold as well, can provoke seizures like sleep deprivation. And alcohol has a predilection for that medial temporal cortex. Somewhere along the line, I learned that every ounce of beverage alcohol kills 10,000 brain cells in that medial temporal cortex. Don't ask me how they figured that out. But I think it's probably true. It's why chronic alcoholics will have developed dementias and very severe memory disorders, why people have blackouts when they have too much alcohol. So this is a serious issue for all of us just in general. Look, I'm going to talk about this with marijuana and alcohol. They're both legal here in Colorado. And as adults, we're legally empowered to do bonehead things. Kids have a little more control. But, if I wanted to have 3 scotches in the afternoon at lunchtime, that's legal. I could go and do that. It would be idiotic to do it, and God help the patient I see in the afternoon. But so thinking about these things is not a moral issue. It's not a legal issue. It's really about, am I having memory problems? If I am, if I have seizures, if I'm struggling with control of my seizures, I really need not to drink alcohol. I'm going to leave state-dependent learning. Yeah, it's a good example of alcohol. In an experiment that was done some years ago, it could not be done ethically anymore. Everybody worked on college sophomores. They have to be involved in experiments in order to get psych credit. So they took 2 groups of students and they had them study some information. The first group, they got pretty close to drunk. They were drinking while they were studying. Second group, not at all. Then they gave the test for that information to both groups when they were both sober. The group that studied when they were sober and took the test when they were sober did, as expected, reasonably well. The group that was drinking heavily while they studied and then got sober couldn't remember worth a darn. But if you got them drunk, they could remember better. Now, that kind of goes in the face of some of the things that I've been saying perhaps, but the idea is that the brain state that we're in at any given moment is likely to influence how we recall something later on. So this is a big problem with post-traumatic stress, that if people get triggered, they suddenly remember, if they get triggered from something traumatic or stressful they see in the moment, that may bring back memories when they were traumatized early on, because the state of the brain becomes the same thing. Stress. Stress is different for all of us. It can provoke both epileptic seizures in some people and non-epileptic seizures, and some people aren't much affected by it. There's good stress and there's bad stress. I mean, for me, cross-country skiing can be a little stressful because I got to remember stand upright and not go off a cliff, but that's good stress. I may enjoy that. Negative stress, though, increases this cortisol, this hormone in our body, stress hormone, and that actually is correlated with memory impairment and with hippocampal atrophy itself. So the more stress we have, the more likely our brains are to be affected negatively by cortisol, and that can interfere with memory. It's also interesting that many epilepsy patients have increased cortisol levels to begin with that occur because of the frequency of seizures themselves. So that's another factor that can affect memory in epilepsy. I don't want to do too much on psychogenic seizures here. I see I'm kind of running out of time, but non-epileptic seizures, I guess I want to say is they are true events. They're not epileptic or neurologically caused, but they are very real. They're not fake. They're not pretend. They're not getting attention. They're not pseudo. And they can interfere with memory as well for a whole host of reasons. Medication, I mentioned that before. Memory function in people with epilepsy it can go off a cliff as soon as you start adding anti-epileptic drugs. And so every one of your neurologists and epileptologists is trying to get you to one medication or as few as possible to control your seizures, because we absolutely see memory begin to go south the more drugs we add on board. Now, having said that, I just want to make a statement here. It is crucial you never discontinue or reduce any medication for seizures without specific instruction from your doctor. So don't ever go from a podcast like this and take any information, go, oh, maybe I'll improve my memory by stopping one of my drugs. No, absolutely don't. Much worse to have seizures. What you can do is review your alcohol use. Alcohol's a pleasure for adults. It's something that kind of disinhibits us. It makes us a little looser. It's just an adult pleasure. So this is not a moral issue at all. I used to like going to wine tastings some years ago when they were around, until I really began to read the alcohol literature, and I realized that alcohol is just not good for our brains. I still have a glass of wine with dinner. That's not an optimal thing for anybody to do, it turns out, but I'm an adult and I can make a bonehead decision about myself. Now, if I had epilepsy, that's going to lower my seizure threshold. That's going to make it more likely I'm going to have a seizure even on medications. And I would stop drinking at that point. However, if anybody out there is drinking more than 2 glasses of wine a night, or 1 or 2 beers, or 2 beers or more, I would say 2 drinks or more, you should not stop cold turkey. People should go down gradually, because you can have seizures from abrupt alcohol withdrawal. And again, if alcohol is a problem, you should talk it over with your doctor. Don't be ashamed, but just make sure they know what's going on, because they can help prevent seizures as you come off of alcohol. Marijuana. Not as innocuous as those of us in my generation, hippie generation, used to think. You smoke a little pot, no big deal. You stop smoking it, no big deal. Marijuana and cannabis absolutely affect memory and thinking. And if anyone is using marijuana or cannabis regularly, I like them to, and I can't prove this with anybody, I have to take them at their word, but I like them to really stop for about 5 to 7 weeks before I do a diagnostic memory evaluation, because I know the answer is going to be yes. Their memory is going to be less good than it would have been if they weren't using cannabis or marijuana. We know that it stays in your system longer than just using it, because you know about hair tests. Doctors can do hair tests and determine whether you've had any cannabis in the last 3 months. So it stays in your system a long time. Cannabis also interacts with medications. It can change blood levels. It can contain harmful substances. We're seeing now with the big marijuana industry, if they use organophosphates, they get more of a yield and more money for their product. Organophosphate poisoning has occurred, pesticide poisoning with transdermal CBD. There have actually been cases where the growers have sprayed micro pellets of lead on their product to get more money for, excuse me, less product, and had lead poisoning occur in patients. The problem with marijuana is that it's not controlled by anybody. And they've done some studies here in Colorado, pardon me, where they assayed, I think it was 100 different dispensaries, because they lay out which receptors are affected, how much THC, how little THC is in there. And the accuracy of those descriptions was found to be 0. It's essentially made up. You do not know what you're getting. And it's not that the people selling it are lying to you. I think most of them believe what's written down there. It's just it truly, there's no way to know those things, and it's not known. So physicians, doctors of medicine, and neuropsychologists, we're not trained very well in that unless you get special training in it. And doctors are sometimes really wrong about, oh, that's a harmless thing, or, oh, that's not going to hurt you at all, or, oh, that won't be a problem. And so it's really important to think carefully and critically about that. Speak with your doctors about it if you're having any memory difficulties at all. And by the way, that's separate from if you're getting it for medical reasons or not. It still has the cognitive problems, whether it's prescribed or not. You may need it or may be appropriate for you. Again, it's important not to stop cold turkey. Turns out about 18% of adults are classically addicted to cannabis and marijuana, just like heroin. Some studies have shown it actually can be more addictive than heroin because it's more fat soluble and it attaches to the lipids in the bloodstream and stays there longer. So if people are using it heavily or regularly throughout the day, they should titrate off it, come off it slowly and gradually to keep things from happening. You can also have hypertensive episodes and a variety of other problems stopping cold turkey. So I never tell my patients to stop cold turkey. Okay, how do you optimize and protect your brain health? Sleep, obviously. Pardon me again, that's not COVID, by the way. It's a lousy bronchial irritation that I got with all that fire smoke that came in and hasn't gone away from the summer. So good restful restorative sleep, for all the reasons I gave, is one of the most critical things you can ensure goes well for you that will protect and improve your memory. And if you find that if you think you have apnea, that is not a minor thing. It increases your risk of dementia, Alzheimer's disease later on. It will provoke seizures. It massively increases people's stroke and heart attack risk at night. And for men, it's a big risk factor for impotence. And so untreated sleep apnea is just something that needs to be taken care of. Restless leg syndrome, waking up and finding your legs are moving without you really wanting them to, it wakes you up, that can be treated easily too. And that's something that a treatment of can improve thinking. Exercise. Okay, I used to roll my eyes when Brian Bishop, my doc, used to say, Jay, you got to get more exercise. I'd say, Brian, I sit all day. How am I supposed to get more exercise? I say, you need more exercise. And we would go back and forth. But it turns out that for the brain, exercise not only is helpful in perhaps preventing or certainly lessening the risk of dementias, but also improving memory. Now, I guess it makes sense because if you do aerobic exercise, you are hyperperfusing your brain, your heart rate is going up, your blood pressure goes up, you're oxygenating more of your brain tissue. I mean, I think that's probably, what do I know? But I think that's probably what just is helpful to the brain. And the standard memory improving and helpful paradigms we use is 3 to 4 times weekly, 30 to 45 minutes of aerobic exercise. getting your heart rate up, or two times weekly of 60 minutes, maybe with some strength training too. There is no question that this protects and improves brain health, none whatsoever. So the only caveat here I have is that your doctor needs to okay that for you. You don't want to hyperventilate in general with epilepsy. So talking to your physicians and getting an okay before starting an intensive exercise program is important in epilepsy. Yoga has been found to be a very helpful alternative. Probably does just as many things. It actually has an anti-inflammatory effect in the brain and in the body. And there were some very interesting studies some years ago where yoga helped control seizures better than medication in patients who were having intractable seizures. And it was a study, I think, done at Oregon Health Sciences Center and at the Yale School of Medicine. But it's not something to do instead of taking your medicine, but it is something to consider adding. Hearing loss is an independent risk factor for dementia. If you have hearing problems, get your hearing tested and taken care of. Alcohol, as I meant, a plant-based diet. It turns out that without question, and on my website, if you go to, I'm going to sound like one of the politicians, www.drjschneiders.com, I have a whole section on diet and brain health. And it's incontrovertible now. There are thousands of studies, I think, on diet and brain health, that the more you move toward a plant-based diet, a delicious plant-based diet, the more likely you are to live longer, your heart work better, have less heart disease, but also have fewer brain problems. And people ask about supplements. Adequate B12 is really critical. Most people get it from a good diet, but having your B12 checked if you're having memory problems is one of the first things to do. And then N-acetylcysteine is something a lot of neurologists are using as a supplement. It's over the counter. I always recommend just talking to your doctor about this. My sense is of the reading, extensive reading I've done, there really aren't adverse side effects to be too concerned about there. But again, even though doctors of medicine are not trained in nutrition, I think it's always wise to run anything that you start across the desk of your doctor, just to make sure that there's not a particular contraindication for you. When to ask for a memory evaluation? Well, if at any point you find your memory is not functioning well and it's affecting your work or your study or just getting around and doing the things you enjoy doing. If you're older, if you're over 60 and you or your family notice memory function, it seems to be getting progressively worse, more than you think would be just the problems with aging, that's a time to get an eval. And then if there are any really bizarre or extremely unusual loss of memory, like I said, the person who forgot that he'd been on a cruise 6 months before, or really severe decline, falling off a cliff type of thing, you want to get your memory evaluated. So who do you see? Well, I'm a neuropsychologist, and neuropsychologists are just like neurologists in the sense that we go to college, then we go to medical school or professional school for 4 or 5 years, then we do a year internship in a hospital, then we do a residency and we can do fellowships. So it's a parallel process to neurology. And there's a board certification process called American Board of Professional Psychology. It's there. You can be a fine neuropsychologist without being board certified, just like you can be a good medical doctor without being board certified. But it does ensure you that the person has had at least certain levels of training and is not just calling themselves a neuropsychologist. And then I would ask a neuropsychologist, did you get trained in epilepsy? Did you have a seizure disorder rotation? I want to know if it's fairly specific. Some of us subspecialize: movement disorders, traumatic brain injury. And if I had epilepsy, I'd want to see somebody who's pretty expert in my condition. Same with Parkinson's. I don't do traumatic brain injury because I'm not expert in it. And so I don't see war veterans who've had IED explosions or football players. Because that's not my subspecialty. So find somebody who knows their area and has been trained in it. Neuropsychology now, sometimes neuropsychologists will talk to you for about 15, 20 minutes. Make sure you're not going to kill yourself or somebody else. and send you off to a technician to do all the testing. I don't work that way. It's just my way of doing things. I'm a dinosaur. When I go to the doctor, I want to see the doctor. There are many good technicians out there. It's not that, I mean, that's becoming a model. We all know we're seeing mid-levels now. Some mid-levels here in Denver in neurology are better than a fair number of neurologists going around, in my estimation. So I do my own evaluations, which lets me kind of craft it to you or to whoever I'm seeing. It's not just a bunch of numbers. It's all these other things we've talked about: sleep, stress, depression, our backgrounds, the medications we're on. All these things need to be factored in, not just a bunch of numbers, your scores on a memory test. And that last thing is the psychometrist is the equivalent of a nurse practitioner or a PA in my field. Thank you.